I'm Dr. Tatiana. Hello, everybody. I'm professor of the Department of Propedetics of Internal Medicine in Dnipropetrovsk Medical Academy, and I want to invite you to the lecture as to the main symptoms and syndromes in kidney pathology. So, this lecture contains from two parts, and it is new version as to May 2020. So let's start. And I want to call to your memory as to the kidney anatomy. So kidney, a paired bean-shaped organ that cleans the blood and through the function of urine formation regulates the body's chemical homeostasis. So let's go on to identify microscopic structural and functional unit of the kidney, nephron. And there are 1 million near that S2 kidney. And as you see here, there is the site of filtration, site of secretion, and site of urine formation on the base of the main function of the kidney excretion function, which contains filtration and reabsorption and secretion. So, what are the kidney's function? So, excretory function, metabolites, drugs, toxins, hemostatic function, maintains water balance, electrolyte balance, acid-base balance, and then endocrine, hormonal function. For the first secretory, renin, erythropoietin, prostaglandins, and metabolic endocrine function. You know that kidneys converts vitamin D3. So, on the basis of this function, the kidneys regulate the function of organs and systems. For the first, cardiac activity, then blood pressure, then blood formation, bone structure, regulation of blood pH, and metabolic and products excretion. So that's why kidney is vital, important organ, as we know. So approach to the patient with kidney disease. What we have to start with? You have to know that main syndrome represents these problems are. There is the list. From it, we will form the box of main small syndromes, pain, urinary edematose, hypertension for the first part of the lecture, and the box of main major syndromes. It will be nephrotic, nephritic, uremia, renal failure syndrome for the second part of the lecture. So let's go on, and I wanted to announce that we will start survey algorithm from the observation and general survey. And for the first, we have to check vital signs and go step by step by main methods of physical examination of the status, objective status of the patient, and then we will make the conclusion and form the plan of laboratory and instrumental method of examination to verify our general hypothesis about the problems. So let's go on, and general inspection. What is your first view as to the patient with the kidneys pathology? So it will be typical edema. And edematous phase, as you see, paraorbital edema in the morning priority, both sex and the general edema signs with feet swelling or legs swelling or morning hands swelling, and this edema will be warm and soft. And as to the main complaints, for the first, it will be disorders of urination, dysuria, frequency, nocturia. There may be fever with chills in some cases, and What about pain? It may be acute loin pain, dull H, then bilateral or one side, and let's go on for the typical signs of kidney pain. So, what are they? Cardinal features of kidney and urinary tract disease, upper urinary tract symptoms, and it will be loin pain or tenderness, renal infection, renal infarction, glomerulonephritis, then severe loin pain, renal or ureteric colic, with or without irradiation to the iliac fossa, groin or genitalia, for the acute obstruction of renal pelvis or ureter by calculus or blood clots. Let's go on, and here you see the area of pain typical for kidney problems, and bilateral or one side, and more typical bilateral for glomerulonephritis. And here you see renal colic representation and the severity underlined here at these pictures. And I want you to pay attention to this fourth position of this guy. Right side you see here, and you see flex knees to the abdomen and the severity of the pain on his face, typical for paranephritis. So, as to the cardinal features of kidneys or urinary tract disease, as to the lower urinary tract symptoms, so it will be dysuria, frequency, urgency, lower urinary tract infection, impaired urinary flow, hesitancy, dribbling of urine, incomplete emptying of the bladder flow obstruction, or urinary retention, incontinence, or enuresis, sphincter or bladder wall dysfunction. So, it may be pain, or it may be pressure, or it may be painful urination, but you have to know these symptoms because you have to identify, is it kidney or different levels of urinary tract involved into pathological process. Let's go on for another complaints. Changes during urination. So foamy for proteins urine, blood in the urine, and increase or decrease in the volume of the urine compared with ordinary diuresis, and need to get up at night to urinate, and frequent urination. The term is dysuria. Then painful or difficult urination, it will be pollakiuria, or waking up to avoid more than 2-3 times per night, nocturia, or urgent incontinence. So we spoke about low back pain, we spoke about swelling, and now you have to pay attention to the fatigue as the general complaint, lack of energy, and feeling weakness while physical exertion, and less of tolerance to physical exertion, typical for kidney disease. So let's go on, and this picture tells us about frequent urination, for example, as to the overactive blood in nevus persons. Or another name is urge incontinence. So you have to understand the reason of it. And in some cases, at the patients, in the case of patients over 65, there are serious reasons of this sign, and you have to identify them. So let's go on, and you have to identify also the history, medical and family history of this person. So family history of renal diseases is very important to understand the problems of the patient. The time of onset, you have to identify by your questions. The onset of the symptoms of renal dysfunction. So the changes in bladder function, including nocturia, polyuria, and hesitancy. So fatigue and weakness. So dyspnea on exertion, which can be manifestation of fluid overload or acidosis. So let's go to the edematous syndrome. And you have to recognize such a patient. So want to highlight once more by the facies nephritica, both sex, and you see the color of the skin, the color of the face, and it will be the priority of morning edematous face. And as you see here, it may be generalized edema, anasarca, as to retention of water and sodium. So let's go on, and we have to discuss the pathophysiological mechanism of kidney edema. And for the first, it will be primary sodium and water retention, the way to hypervolemia, then increased capillary hydrostatic pressure and water transudation to the interstitium with edema signs. For these cases, it's typical generalized capillary permeability. So, but what I want to highlight, no increased synthesis of hormones, renin, aldosterone, angiotensin, and antidiuretic hormone will also be by the normal levels, and the same will be catecholamines in the blood. So, urinary syndrome is the specific syndrome for kidney pathology. So, what is it? Quantitative and qualitative changes in the urine. Key points. Symptoms. Changes in the volume and consumption of the urine output. Changes in the rhythm or urinary excretion. Changes in volume and consumption of the blood. So let's go to understand the cardinal features of kidneys and urinary tract disease. So for the first, abnormal urine volume. And normal, as you see here, 1 to 2 liters per day. When it will be 500 milliliters per day or less, up to 300, it will be dehydration, blood loss, diarrhea, and we name it oliguria. If less than 50 milliliters per day, it will be the sign of kidney failure or kidney acute injury, and it will be anuria. Then it will transform into stages of polyuria, more than 2.5 liters per day. And it may be also at the cases of diabetes mellitus, diabetes insipidus, or in physiological cases with excessive water intake. In the case urine greater than 35% of normal 24 hours urine volume, it will be nocturia, and it will be nocturnal polyuria. And as you see here, based of nocturia, waking up to void more than 2 or 3 times per night. So, and now I want you to pay attention to this painting, ancient painting from the 14th century manuscript at the doctor. And you see ancient physician with the urinarium in his hand, and the line of his patients brought this test to him to understand the problems. And a lot of urinariums here and the office, ancient office, because it was the most general and the most important test for diagnostic process in the ancient centuries, and then in the middle ancients of the mankind history. So let's go to physical examination. And the Asian doctors, as we are analyzed for the first, the color and clarity of the urine test. And as you see here also, order, volume, and normal results, right side, and the meanings. You have to stop slideshow to identify what is the meaning of the disorders. Then the chemical examination and specific gravity, pH, bilirubin, glucose, and so on, so on. And you have to identify white blood cells or maybe red blood cells, bacteria, parasites, casts, crystals, and so on as normal or abnormal data. So let's look for urine specimen. What is the most important? First morning specimen. But it will be random during the day. As to admission the patient to the hospital, for example. Or you may also examine midstream clinkage specimen or different type of another tests for specific patients or time collected specimen, and they are very important to understand the problems of the patients. So for the first lab tests of the urine, and we will start of gross appearance and physical observation of the volume and color, and then turns to the microscopic examination of cells, and then biochemistry for pH, glucose, proteins, and we will stop as the Asian physician from horoscopy and analyze urine colors, for example. And as you see here, they changes as to the specific gravity and water intake. So what is the normal urine test? So clear, amber yellow, aromatic or odorless. Then pH average 6.0 and protein less level as to the deciliter or as to the 24 hours collection. You see here lower contain protein urine, and it is at rest. If during exercise, it may rise up to 250 milligrams per 24 hours, and it is very important to understand this level and to remember. Then specific gravity, as you see usually in the morning urine, it will be 1.015 more often, and up to 1.025. As to water intake, then look here, and we will go to non-chemical examination, and then you see here less of glucose, and what is important, white blood cells less than 5 in high power field of microscope, and less than 2 as to red blood cells in high power field of microscope, and none casts and none bacteria. So let's go to the disorders and keep poised what we have to know. So gross bacteriuria, when erythrocyturia more than 100 in high power field of microscope will associate with kidney stones, infections of glomerulonephritis, and leukocyturia more than 60 high power field microscope, it will be pyuria associated with urinary infection. Xenophiluria associated with allergic intestinal nephritis. And when casts appears, red blood cells casts, white blood cell casts, then granular casts or maybe waxy casts are associated with the severe damage of tubular system of the kidney. So let's go on, and here you can see red blood cells in the urine, then white blood cells, and as you see here, they contains the elements of pathological agents in, and here coccal infection in the urine test, and then casts and different types of crystals, and high field power microscope will help us to identify these disorders. So what I want to stress, for the first, the changed red blood cells, typical in the urine as to the pathology of the lower urinary tract disorders. And when they will be changed, we will think about the kidney pathology, and it is very important for diagnostic process. Let's go on to the Thompson test, and it will be 3 glass samples. So initial, intermediate, and terminal. And if we will find red blood cells in the initial glass, we'll think about the disorders in urethra. And if in the terminal, we will speak about urinary bladder disorders. And then in all 3 glasses, we see red blood cells. So we'll think about kidneys damage. So next test, according to Zimnitsky, functional test, and we will collect urine every 3 hours, 8 times per day. You see here the time to urinate and the amount of urine at this time have to be assigned, and you have to identify the relative density of the urine in all these portions, and you have to calculate daytime diuresis. It will be near 700 milliliters. Nighttime diuresis in normal cases, it will be near 500 milliliters, and daily diuresis summarized have to be 1,200 up to 2,000 milliliters per whole day. So what will be the disorders? We pay for the first disorders not to the volume, but it is important, but as to the specific gravity of the urine portions during the whole examination. So hypostenuria, when in all these 8 portions, the specific gravity will be less than 1012. Isostenuria will be when the specific gravity vibrate between 1012, 1008, or more often 1010. And hypoisostenuria, the very severe disorder of the function of the kidney, exertion function, it will be less than 1012. And as to hypostenuria, you have to know that it is the criteria associated with the equal specific gravity of the urine as to the plasma without nitrates, and it is inability of the kidneys to concentrate the urine. So, and in these cases, monotone specific gravity is also very important. It means fluctuations of the portions gravity less than 7. And nocturia, as to the volume, priority nighttime above the daytime. So let's go on to the test according to Nichiparenko, which helps us to understand where the disorder is from the kidneys for the first, because it will be the average portion of the urine gathered for the lab test, and it will be 1 millimeter of centrifugated urine, sedimentation exam for the red blood cells, white blood cells, and casts. So as you see here, red blood cells, reference values up to 1,000 cent per milliliter, white blood cells up to 2,000 cells per milliliter, and cast up to 20 units per milliliter. So let's go here to use strips for the quick examination of the urine for screening the patients with the urine disorders. And as you see here, strips may help you to recognize glucose, ketones, bilirubin, or maybe proteins or red blood cells, and not only the qualitative characteristic, but also quantity by the different color of these strips. So let's go on to bacteriuria, and in the case of 10 in 3, it will be false bacteriuria as to contamination of the material. And as the result 10 in 5 per 1 milliliter, it will be reliable, true bacteriuria. For bacterial bodies, tells you about the severe infection, for example, in the urinary tract or in the kidneys. So, and the next is hypertensive syndrome, is one of the very important syndrome of kidney damage. So let's go on, and I want to call to your memory as to the causes of hypertension, and for the first level of representation in the real clinical practice, near 90%, it will be essential without causes of origin, primary hypertension, and then it will be secondary renal hypertension, near 10% in real clinical practice, and hormonal secondary hypertension, near 3% of person will represent the hypertension syndrome in your practice, for example. But what I want to highlight, that renal component of disorders associated with different types of hypertension present in all clinical cases and all types of hypertension. So let's go on to this funny picture. And I want to show you and stress that the kidneys secretion of renin helps to regulate peripheral resistance by influence of conversion of angiotensin 1 to angiotensin 2 as the strongest vasoconstrictor in the human body. And it provocates the enlargement or function of adrenal glands with releasing of aldosterone, which control the sodium and water retention, helps to higher the peripheral resistance and forms the hypertensive syndrome. So this axis of renin, angiotensin, aldosterone, concentration in the blood and influence on the parameters of resistance and cardio output forms all the clinical features of the hypertension's priority as to secondary renal one. So let's look at the secondary renal hypertension origin. And for the first, we'll speak about was renal hypertension as to the renal artery stenosis, for example. And it will be renal ischemia as the result of that. So renin production increases and the level angiotensin 2 rises, influence the production of aldosterone and sodium retention, influence on the extracellular volume and cardiac output. And as you see here, the angiotensin 2 forms the level of total vascular resistance, and both of them influence of the data of blood pressure. Another type of various renal diseases and the functional renal mass loss is the way to the retention of sodium, and the same disorders provocate it others. So you have to know that high blood pressure syndrome we diagnose when the systolic blood pressure will be equal or more than 140 or diastolic 90 or more as to millimeters of mercury. But we also have to pay attention to the pulse blood pressure, which will be 40 or less, typical for diastolic type of disorders of hemodynamics in the case of renal hypertension. And I want to highlight that the heart rate more often will be as bradycardia as to electrolyte disorders, for example, which is typical for renal damage. It will be potassium elevated level or magnesium elevated level forms bradycardia data. So it's the end of the first part of our presentation, and I will see you at the second part in some minutes. Bye.